My name's Dawn. I'm the Senior Occupational Therapist at Nepean Cancer Care, and this is my colleague Jackie. Today I would like to take you on a 5-year journey, which has taken, as I just said, taken place over 5 years. And it started in 2013 when the Allied Health team embarked on a mission to develop a model of care. During this process, it came to our attention that we had not been providing a service to our brain cancer patients. Due to their complex needs and disease progression, we believed this was a service priority. So we undertook a file audit at Cancer Care, and also we looked at the OT home visit registry. And this identified that only 13% of patients that came through our service were being seen by the occupational therapists. Out of the 13 people who had been referred, they had either passed away before we had got to see them, or they had ended up in crisis management in hospital. So we set about doing a joint study with the University of Western Sydney, looking at identifying OT service needs for people with brain cancer. The findings from this study will be published in the British Journal of Occupational Therapy later in the year. There was 2 overarching themes that were identified. The first findings of the research highlighted the need for a more coordinated, collaborative and timely care approach, which in turn will provide quality of life, decrease crisis management and reduce the risk of hospital admission. So, using the ACI redesign methodology, we invited all the health workers at Nepean Cancer Care, and that included the doctors, nurses, our palliative care team, and also the Allied Health team on our busy neuro ward. So everybody that was involved in the journey. Secondly, the second theme was looking at how best do OTs provide their service, and looking at the gaps to meet the unmet needs of this population group. So the aim was to explore the impact of brain cancer on quality of life and to better understand occupational therapy service needs when providing a holistic approach to patient care. The model we adapted to guide best practice was the Person, Environment, Occupation and Performance, or the PEOP model. We chose this model was because it was client-centred and it organised to improve the everyday performance of necessary and valued occupations of the individual. So the methods we used to do this project was to undertake ethics approval through our local hospital, Nepean Hospital. We again reviewed current practices by completing yet again another file audit at the centre and identified gaps in the service to determine when we were being referred and why we were being referred. We extracted information from the previous 2 studies, so that was the model of care and also the 2-year project with the uni. We conducted extensive education sessions to staff at the centre and on the neuro ward to increase the awareness of the occupational roles in brain cancer. We asked all staff to complete staff surveys, and we also asked patients to complete surveys as well on the service that they are being provided by the OTs. We attended newly developed MDTs in collaboration with the radiotherapists and Allied Health, and we also started to attend our new CNS MDT meetings, which would help generate early referrals. We decided to accept blanket referrals, so everybody that came into our centre, if they had a diagnosis of brain cancer, they were then referred to us. We wanted to really increase our referral rates from that 13%. We developed an initial interview form by utilising the PEOP model to obtain vital patient information and guide our interventions. We developed a brochure which we could hand out to all our patients, and it explains the role of working as an occupational therapist with brain cancer patients. We have also developed a satisfaction survey to be completed by the patient throughout their journey. And I should let you know, we are involved from the very beginning of their journey, from diagnosis straight to the end of their journey. Throughout that process, we try and gain as much information from the patients or the carers to see whether or not we are providing those unmet needs. And we are continuing to evaluate and monitor the project as we go along. So currently our results, if you remember pre-study, we were only being referred 13% of our patients. Now, that figure should say 96%, so not 9. So as you can't see, we have significantly improved our referral rates from 13% to 96%. I'll just hand you over to Jackie now, who will talk a bit more.
Hi everyone, and thank you, Dawn. So just following on, along with the increased referral rates that Dawn has just mentioned, there were also a number of other significant implications that came about from this newly developed comprehensive service. These increased referral rates directly allowed more patients and carers a timely access to not only us as the OTs, but also the medical and other allied health professionals when it was appropriate. This made for an extremely efficient and coordinated approach to care, as patients were known to us much earlier, so we were able to liaise with and involve other health professionals depending on the patient's needs and goals. So from here, you can see that there is a positive flow-on effect. Because we were already aware of the patient, we had already built rapport, and we were already aware of their goals, we were able to avoid crisis situations for the patient and their carers. Now, by reducing these crisis situations, which were often quite stressful and quite often led to hospital admissions, meant that patients were able to stay at home for longer. And if they did present to hospital, we were able to facilitate a more efficient and timely discharge. This project also helped raise the awareness of what services and supports are available to brain cancer patients and their carers, as it was found that many people and their carers were simply unaware of what services were available. And finally, which is probably the most significant implication, is the improvement in the quality of life for brain cancer patients and their carers. It is important to highlight that this was ultimately achieved by the combination of all of the above factors, by making the patient journey somewhat easier with the continuous support from the beginning to the end of their journey. Now, in terms of the overall outcomes, like Dawn has said, we were able to revise and evaluate our occupational therapy practice as a whole. We have been able to shift our practice away from a crisis management and quick fix point of view and transform it into a much more comprehensive practice with a collaborative, efficient and holistic approach to patient care. It was also found that in order to maintain this high quality level of care, it was essential to have a care coordinator position. Now, this would be of extreme benefit to facilitate appropriate referrals and also be the patient's first point of call for any questions or concerns, which is quite common in this particular patient group. Now, over the course of this project, it was actually Dawn and myself who were acting as the brain cancer care coordinators, on top of our normal OT duties, which unfortunately is not all that sustainable in a busy cancer care centre. And last but definitely not least, what has made this 5-year journey possible is the acknowledgement of every single person involved in a patient's journey being of equal importance. So this being each health professional, including allied health, medical professionals and nursing staff, along with empowering the patient and carers themselves to be the driving force behind their own interventions and their care plan to achieve their own individual goals. And finally, just to finish off, I just wanted to leave you with a couple of the testimonials that we have received throughout this project, which I guess highlights why we do what we do, which is to offer some kind of positive impact into the lives of people living with brain cancer. Thank you very much for your time.
Thank you. Questions? Here we go.
All you're talking about there, and thank you for the information, is you're working with your occupational therapist. Where's the holistic side within that? Now, I'm a holistic healer, and believe you me, I don't know any occupational therapists that actually practice it, because it's what it says. It's all of body, not just a particular part.
No, I agree with what you're saying, and that comes up quite a bit of time. And when we say holistic, the way that the occupational therapists work is a holistic approach, looking at the functional, the cognitive, the psychosocial, the whole journey, if you like. When we say holistic approach, that also relates to having medical on board, allied health on board, the patients, the consumers, everybody involved. So it looks at it holistically. So I guess there's different interpretations of what holistic means. Some people, it's like quality of life. What does that mean? It may mean something very different to me, something very different to you. It's just an approach, and it's a wording as far as OTs are concerned, that we look at the person as a whole. We don't just look at your head, we don't just look at your muscles, we look at it holistically.
Well, that's what I've been doing for 20 years. and I have a different approach to it. And if you followed the approach that I and others use, you would find you would be getting a better result from from all your therapies, and you're clearing a lot of the dis-ease out of the mental emotional side of it.
Okay. Thank you for your comments. Just one in front there.
Thanks. I'd just like to congratulate you on the work you've done in providing that, the pathway of care that's being provided. And I'm just interested in knowing whether you are able, given your results, to be able to get some further funding for a care coordinator, because given your own workloads on top of everything else.
We've had lots of consumers, so carers have been trying to advocate for a care coordinator for many years since we've started the project. We have some of our care coordinators here in the room, and they don't just coordinate one tumour group, they have to coordinate about 3 or 4. I don't know how much more we can push it. We've had people going up to the ministry, but I think for me, being so passionate about brain cancer, is that it's not a huge number, so it's not going to get the voices out there like lung or breast. It's only a small cohort, but it's an important cohort that I think we need to really advocate for a coordinator, because we can't continue and sustain it, and neither can the rest of the coordinators.
We had a question down the corner. Yes. Oh.
What quality of life tool did you actually use to measure, if you did use one? Thank you.
There was a lot of quality of life tools. There was one specific by the World Health Organization. I think it was the 33. But because quality of life is we measure quality of life by the goals that they attain, whether or not they are able to reach those goals. So if they can, they can. We use something like the COPM, which is the Canadian Occupational Performance, and that is goal-orientated, so that's what we use. Obviously, one of the questions in the survey was, about quality of life, but for us, it's not something that we.
We've just got one more question over here. Thank you.
Hi, thanks very much. That was a fantastic presentation. Just looking at your referral changes, I think I'm keen to hear how did that impact on your resourcing? Because to go for such a huge increase, was that a bit scary, sort of saying we're going to open up this massive can of worms, and how do you cope with that? I think we all know that clinicians can only do so, they do everything they can, but we need to preserve that as well.
Yeah, I agree. At one stage, we had 10 active brain cancer patients, so GBM patients, on our books at one time. We didn't think we would get as many because we did an audit on our system and showed that there would be about 14 to 16 come through our centre, but unfortunately because they're doing more surgery, we're getting in referrals from Macquarie coming through now, so our referral rates have gone up. How do we sustain it? About 10:30 you'll see us having a coffee, and that's how we sort of debrief, but we need to look at what we can do but we don't want to let it go. So it's something that we've both been quite passionate about.
Is there any opportunity for you to look at health economist appraisals of, you're looking at reduced length of stay, etc., to show the savings of your model?
We haven't got any statistics out there. I can just say to you, we know the patients when they come in, so it decreases the length of stay from the OT perspective. But also it helps in their journey as well to see a familiar face. We'll go in, sit, and just to see a familiar face when they're on the ward surrounded by the unknown is just enough for us to say, yes, we've done a good job. But I can say we've stopped people from coming in. We've stopped people, we look at their goals and they say, look, Dawn, Jackie, we want to pass away at home, and we will try and facilitate that. We did a quick audit of whether patients had been able to die at home or not, and it was 50-50. And the only reasons people were coming in was because of carer stress and they were unable to cope anymore. So that, even if we could just achieve that 50%, that's worthwhile.
Great. Well, could you all please join me in thanking the presenters for a great session today?